I'm Harriette Van Spall, cardiologist and clinical trialist from McMaster University in Canada, and I'm so delighted to have my friend and colleague, Dr. Darren McGuire, professor of medicine from UT Southwestern, who is principal investigator of the SOUL trial that has made news here at ACC 25. Welcome, Darren, to this discussion, and congratulations on your presentation.
Thank you, Harriet. It's good to see you.
So tell us about semaglutide. I mean, everyone knows the drug, the class of medication that it belongs to, but perhaps you could give us some context that sets the stage for the trial and the research question that your team sought to answer.
Sure. So semaglutide is a long-acting GLP-1 receptor agonist, initially approved as an injectable once weekly, first for type 2 diabetes and subsequently for overweight and obesity. It's really changed our landscape along with the other members of the class with evidence for cardiovascular risk benefits. And so this class of medications with proven efficacy have risen to level 1A recommendations for people with type 2 diabetes with or a high risk for ASCVD, but all of the previous therapies have been injectables. And so we have a lot of patients who are hesitant or even resistant to take an injection medication. And we have a lot of prescribers who are hesitant because they just, there's a really an unvalidated fear of this needle. It's a tiny little needle. We can't feel it go in the skin, but still we can't get a lot of our patients who both have indication and access to the therapy to take the medicine just because of the fear of the needle. And so developing an oral formulation has been revolutionary in the field, and the oral semaglutide that we tested has been proven to lower A1C, similarly to the other members of the injectable class, and is approved for use for type 2 diabetes to reduce hyperglycemia. It also has a dedicated previous cardiovascular safety trial called Pioneer 6 that was designed to show safety but not efficacy for cardiovascular outcomes, and that was successful. So it has a claim of cardiovascular safety, but in this field of medications, safety is not enough anymore. We need to prove efficacy, and so we designed the SOUL trial to test whether oral semaglutide can reproduce the cardiovascular benefits that we've seen with the injectables.
Right. And your patients had diabetes and then some kind of cardiovascular disease. Tell us about the inclusion criteria and who these patients represented.
Yeah, and so the key inclusion criteria were age greater than or equal to 50 years old, at baseline an A1C between 6.5 and 10, and had to have at least one of 4 enrichment criteria: coronary artery disease, peripheral arterial disease, cerebrovascular disease, or chronic kidney disease. They could have any one or any combination of those to be eligible for the trial.
Right. And chronic kidney disease was defined by a reduction in GFR. You didn't test for albuminuria per se.
That's true. This is a purely EGFR defined CKD definition. So EGFR less than 60 was the criterion to get into the trial. And we didn't measure at baseline nor during the trial UACR. We've been criticized a bit for that, but the reason for that was there was a parallel trial, as you know, the FLOW trial that was going on with dedicated CKD enrichment and dedicated surveillance both at baseline and during the trial of urine albumin. And so, this is not necessarily a kidney disease population, and we'll get back to that when we see the results. But, compared with the FLOW trial that had an average EGFR at study entry of 45, our trial had a EGFR on average of 77. So this was a cohort with pretty preserved kidney function, although 13% of those that we enrolled had isolated CKD without ASCVD. So we do have a sizable population with just an EGFR compromise.
Sure, and that gets into the baseline characteristics. You might as well present the rest of the characteristics of your population.
Sure. So we enrolled 9,650 people to once daily oral semaglutide versus placebo. At the end of enrollment, we had an average age of 66, average duration of diabetes of 15 years, so pretty advanced disease for diabetes. BMI was 31. So this is pretty similar to the patients we see every day in the clinic, and so pretty generalizable patient population. We had an imbalance by sex, which we see in a lot of ASCVD-driven trials just because of the age criteria, and men develop ASCVD earlier than women. And so we had about 70% men, and the balance, obviously, of women. And so always we're trying to push the needle to get more equity of enrollment. And, we can always do better. But again, 30% of a 10,000 patient trial, we have 3,000 women in the trial. So a pretty robust sample size to evaluate outcomes stratified by sex.
And who are the patients in general? Did they mostly have cardiovascular disease? What was the breakdown of some of these comorbid conditions that were enrichment criteria?
Yeah, 80% had prevalent, about 80% had prevalent, or 85% actually had prevalent ASCVD. Most of that was coronary disease. About 60% had coronary disease, and a balance between PAD and CVD, and some had 2 or 3 of the criteria. So, but it was driven mostly by coronary disease, and again, pretty much the patients we see daily in our cardiology clinical practices.
And what was the uptake of SGLT2 inhibitors in both groups?
Yeah, great question. So at study entry, over 25% were being treated with background SGLT2 inhibitor, which is almost double what we've seen in any previous GLP-1 receptor agonist trial. And during the trial, 50%, 50% during the trial, 50% at some time were treated with SGLT2 inhibitors. And so we have as I think you're aware, we had a simultaneous publication in Circulation, a deep dive on the stratification by background SGLT2 inhibitor use, evaluating whether the efficacy is independent or not of SGLT2 inhibitor background.
Okay. Now tell us about the treatment regimen. So this is an oral formulation. It's a once daily pill that patients take, and they started off with 3 milligrams that got up titrated to 7 after a month, and then to the target dose of 14.
Yeah, those are the doses, just to point out, those are the doses that are approved for treatment of hyperglycemia. So these are the medication doses that are available already clinically. And just to point out, so this is a novel technology of drug delivery with a technology developed by Novo Nordisk, the trial sponsor. They use a molecule called SNAC, SNAC, and I won't even try to pronounce what that stands for, but it's a so-called sticky molecule, and it makes the tablet sticky in a gastric pH, an acidic pH, and so the tablet actually sticks to the gastric mucosa, and it's at the point of contact of the tablet that the drug is delivered. It's a highly inefficient delivery system. So only 0.8% of the drug in the tablet is actually taken up into the bloodstream, and 99.2% is excreted in the feces. And so, but dosing at 14 milligrams once daily, or roughly 100 milligrams a week, reproduces pharmacokinetically what is achieved with a 1 milligram once weekly injection. So it was as close as we could get to the dose exposure that has been proven effective both for hyperglycemia, but importantly for ASCVD risk reduction with the injection.
Sure. So patients take the oral pill in the morning, first thing in the morning, with water, and then don't eat anything for 30 minutes. And I'm saying this for the clinicians in the audience who would prescribe the therapy. So it's a bit different than the subcutaneous version, certainly. Tell us about your primary and secondary outcomes and your testing strategy.
Yeah, so like almost all of the antihyperglycemic trials since the regulatory guidance changed in 2008 requiring cardiovascular safety assessment, the primary outcome was 3-point MACE, cardiovascular death, MI, and stroke. And we had a hierarchical testing strategy. So if we had superiority proven on the 3-point MACE, we had 3 pre-specified confirmatory secondary outcomes. And those included, in order of analysis, a 5-point composite CKD outcome, cardiovascular death by itself. And then importantly, as we'll get to the results, a peripheral arterial disease outcome, what we call major adverse limb event of hospitalization for acute or chronic limb ischemia.
And what was the strategy or the rationale for that particular hierarchy? Because I always think of kidney outcomes particularly those ones as being some of the later events in the disease trajectory. So it must have taken courage to choose that as the top of the hierarchy of secondary outcomes.
Yeah, as you've been involved in trials, we spent hours debating
Yeah.
what outcomes
Yeah, I
in what
bet.
order, right? And hindsight's 2020, and you always wish you might have done something a little differently, but that's what we settled on. And the data at the time we designed the trial suggested that this drug class was going to be effective on CKD. And in fact, in the
Sure.
interim, the FLOW trial was conducted and reported and proved that
Okay.
semaglutide at 1 milligram injection weekly favorably affects in a CKD enriched patient population, not just progression of CKD, but also cardiovascular outcomes. And so we were optimistic, having seen the FLOW trial, that we would have a real chance of success on the CKD composite outcome. And I
Right.
think as we saw the FLOW trial, we could have changed the hierarchy depending on the FLOW results, but I think FLOW gave us support for the order that we had predefined.
Sure. Now we're all excited about your primary treatment effect. So tell us what that was.
Right. So we had statistical superiority with oral semaglutide versus placebo and again, this is on the backdrop of open label treatment of hyperglycemia to local and regional standards and a very well treated patient population for cardiovascular risk mitigation therapy. So this is a really well treated population, and that's important to understand that the observation is on top of the best available therapy. And so we were able to demonstrate a 14% relative risk reduction, highly statistically significant, and so proven superiority. And very interesting, when we saw the data, the point estimate and the confidence intervals to the 1,000th decimal place fall right in lockstep with the meta-analysis of the field that had been previously published. So if in the previous meta-analysis, the point estimate is a 0.86 relative risk reduction or point estimate, a 14% relative risk reduction. So these results are precisely in line with the field. Now I'll take a step back and remind the audience that the injectable semaglutide form of 1 milligram once weekly had a point estimate of 0.74 or 26% relative risk reduction. And that outcome was in a smaller trial with a little less robustness of the point estimate, a little bit of fragility because it was a smaller trial with smaller number of participants, and it is the outlier in the field. And so I think what we all believe is that was probably a spuriously high estimate of efficacy, and probably the truth is somewhere in between.
Okay. And then tell us about your hierarchical secondary endpoint.
So because we had proven superiority on the primary, we had statistical privilege to analyze the prioritized confirmatory secondary outcomes. And first we analyzed the 5-point chronic kidney disease component. And directionally, it was favorable. It had a point estimate of 0.91 or a 9% relative risk reduction estimate, but it failed to achieve statistical superiority with a p-value of 0.09. And so having lost on that statistical superiority test, all subsequent analyses become exploratory.
Sure. And we should point out what that 5-point kidney disease event encompassed, because you didn't have a change in albuminuria. These were quote unquote hard endpoints, difficult to move the needle on, arguably. And so I'll give you a moment to just tell us what those endpoints were before we move on.
Sure, it was cardiovascular death, kidney-related death, a sustained EGFR reduction of 50% or greater, achieving an EGFR below 15 milliliters per minute, or initiation of chronic kidney replacement therapy.
Okay. So a sizable reduction in the primary endpoint, but not in the secondary endpoint that was at the top of the hierarchy. Now tell us what some of these other exploratory endpoints were, the treatment effect
Right.
was.
So although we couldn't hypothesis test then the cardiovascular death outcome, but so we report a point estimate and confidence intervals only. So for cardiovascular death, the point estimate is 0.93 or a 7% relative risk reduction, so directionally favorable. But again, the confidence intervals cross unity, so failing to achieve statistical nominal significance.
Right. And then you had some important measures of metabolic function that were really insightful in terms of mechanistic insights. Tell us about those.
Yeah, let's talk about the fourth confirmatory endpoint, because I think that's one, after all this dust settles, that may become the most impactful observation from the
Sure.
trial, to
Yeah.
be honest, is that was the hospitalization for acute or chronic limb ischemia. And that did achieve nominal significance, a large 29% relative risk reduction in confidence intervals that exclude unity. And so, although it's exploratory in this analysis, I think it's going to be an important finding that we will be exploring and hearing more about, that this therapy actually appears to improve clinical outcomes of peripheral arterial disease. And as you know, the STRIDE trial was also reported at and we won't go into the great details of the STRIDE trial that Dr. Banaka led, but that was a PAD trial with injectable semaglutide, and they also demonstrated statistical superiority for clinical PAD events. And so we are already in process of pulling those data from our trial and his, and we'll be reporting a meta-analysis of the two trials that will clearly bring home the fact that this drug appears to be a favorable PAD intervention.
Right. So really nice broad evidence base to support the class of medication across vascular conditions now, right? Because we have diabetes, cardiovascular disease, we have heart failure, we have chronic kidney disease, and now peripheral arterial disease. And you have added to that with this oral version of semaglutide. You also showed a reduction in mean hemoglobin A1C, body weight, and in C-reactive protein. Tell us what the implications of those are.
Yeah, so I think these are important observations, because what it shows us is that the people on average uh, got the drug, right? And so hemoglobin A1C was lower with oral semaglutide versus placebo at a level of about end of treatment difference of about 0.6%. And again, this wasn't a glycemic control trial. The patients were treated to the same A1C targets. And despite that, oral semaglutide was superior statistically for A1C. Body weight was reduced, placebo subtracted difference of about 6 kilograms. And CRP was reduced acutely and sustained throughout the follow-up period by about 30%. And so all of these parameters are pretty much in the paradigm of the injectable drugs. And what this tells us, going into the trial, this tablet isn't extraordinarily complicated to take, but it does take some attention to take it right. And when you give it to 5,000 people, how do you know they're actually going to take it as directed and actually get exposed to the drug? And so these parameters, along with the efficacy demonstrated on 3-point MACE, tell us that this drug in a large population can be used effectively and makes findings generalizable, I think.
Tell us about the safety and tolerability.
Yeah, we didn't observe any unanticipated safety signals. GI side effects, mostly mild or moderate and fairly short-lived, were more common with semaglutide. And again, telling you that patients are getting the drug because the drugs are expected to cause some GI distress, especially in this at the early initiation phase. These symptoms, along with the injectables, tend to go away after dose exposure for over a period of 2 to 4 weeks or so. And then if people stay on the drug, they tend to tolerate it. Interestingly, premature discontinuation of study drug in the semaglutide group was 22%, and in the placebo group, it was 29%. So people stopped investigational product more commonly in the placebo arm, telling us that the tolerability was at least as good, if not better, than a placebo. So, so that was reassuring. And we don't like 20% people not being on drug, but this was a median follow-up of over 4 years. And so we see this in most chronic therapies, that there is simply attrition of adherence to the protocol. And this was actually below our performance standard that we set out to achieve. And on average, 88.5% of intended dose exposure was achieved in both arms. And so people took the drug pretty reliably and great tolerability, honestly.
Well, Darren McGuire, congratulations to you and the Novartis team, the trial steering committee, and all of the trial participants on this first trial of a GLP-1 RA taken orally. And it showed that oral semaglutide was superior to placebo in patients at risk of cardiovascular events, reduced 3-point MACE, and that there were consistent benefits across subgroups. Congratulations. Well done. I loved your presentation, and I look forward to seeing more publications from some of the secondary analyses.
All right. Thanks so much, Harriette.
Nice seeing you, Darren. Goodbye.